The Keynote 522 trial was the first phase 3 trial of chemotherapy and immune therapy, first in the neoadjuvant setting, but then with continuation of immune therapy in the adjuvant setting. The trial was for stage 2 and stage 3 patients with early triple-negative breast cancer. The chemotherapy regimen was a 6-month chemotherapy regimen, which I would consider an optimal regimen, with 12 weeks of weekly paclitaxel carboplatin, followed by 4 cycles of AC or EC, either all the way through with pembrolizumab or placebo, followed by surgery, and then followed by 6 months of pembrolizumab or 6 months of placebo. The trial has 2 co-primary endpoints, a short-term endpoint, which is called PathCR, the complete disappearance of all invasive cancer, and that was positive in 2019 here in Barcelona as well as a presidential lecture at that time, where we showed that the addition of immune therapy to chemotherapy increased PathCR rates by about 13.6% to just under 65%. The second co-primary endpoint is event-free survival, and again we showed this first time after 3 years of follow-up, where we saw that the addition of pembrolizumab leads to a 35% reduction in the risk of recurrences, hazard ratio 0.65. Now with triple-negative breast cancer, it's really interesting. We see most of the recurrences relatively early, after 2 to 3 years. About 70% or even more events occur that early. About 95% of events occur in the first 5 years. And so that's what we've seen in Keynote 522 as well. We presented 5-year data a year ago, where we saw that the EFS curves, the event-free survival curves, are starting to flatten out, with very few additional events between year 3 and year 5. The hazard ratio has remained absolutely stable. Now here at ESMO 2024, we have key new data. We have now a follow-up of 75 months, so over 6 years, which is long for triple-negative breast cancer. In terms of event-free survival, the data have remained absolutely stable. Hazard ratio 0.65. 5 years event-free survival rates are about 81% with chemotherapy and immune therapy, and about 72% with chemotherapy alone. That's highly significant. But most importantly and long awaited are the overall survival data. With 75 months of follow-up, we see a significant improvement in overall survival. The hazard ratio is 0.66. That means it's a 34% reduction in the risk of death, and that's attributed to the addition of pembrolizumab to preoperative and postoperative chemotherapy. Looking at the benefits in subgroups, it seems that this benefit is consistent across all relevant clinical subgroups, whether it's PD-1 positive or PD-1 negative, stage 2 or stage 3, node positive or node negative. So in other words, we can't really identify a clinical group of patients with stage 2 or stage 3 disease who shouldn't be considered for the combination of pembrolizumab and chemotherapy. And for event-free survival, we presented before, even for the smallest cancer, T2 and node, we see a hazard ratio of nearly 0.5 with a substantial delta. So even in the smallest tumors, there seems to be that benefit. An interesting pre-planned analysis was looking at patients who have an optimal benefit and who haven't gotten the optimal benefit in terms of patients who have residual disease at the time of surgery. And we had shown for EFS that patients who have a PathCR with chemotherapy and immune therapy seem to do better than patients who have a PathCR only after chemotherapy. But more importantly, in patients who have residual disease after chemotherapy and immune therapy, there was a lower risk of recurrence if this was after immune therapy compared to after chemotherapy alone. And the same is the case for overall survival. Really exciting, really important from a patient perspective. If you are one third of patients who have residual disease at the time of surgery, but this was after chemotherapy and immune therapy, there's a 6% better chance of being alive at 5 years compared to patients who had only chemotherapy. I think that's really important, really meaningful. In terms of safety, long-term follow-up data didn't show any new safety signals, pretty much what we have reported before, in keeping with previous analysis and with what we know about chemotherapy and immune therapy. So in summary, this is a practice-changing trial. It's already been in all the guidelines. It's already approved in many, many countries and will continue to be. And that's based on the positivity for the 2 co-primary endpoints, improving PathCR rates significantly and reducing recurrences significantly. but most importantly, as we can now demonstrate, also reducing the risk of death by 34%.